Sankara Netralaya.
Good evening, everyone. I'll be taking a class on the evaluation and management of NLDO. This class is moderated by Dr. Varsha Backiavathy. Now we start with the anatomy of the lacrimal drainage system. So it starts with the puncta. Now puncta, they are the openings at the margin of the posterior lamella of the eyelids. So these puncta open into the ampulla for 2 mm, after which it angulates at 90 degree for another 8 mm. The upper and the lower ampulla connect to form the canaliculi. These upper and lower canaliculi connect to form the common canalicus, which then runs for 3 to 5 mm. Now that
So one
joins to
second.
the
So basically, there's a vertical and horizontal canaliculi. Is that clear? Yeah. Okay. And then they join to form the
common
common
canaliculi.
canalicus. Yeah.
This common canalicus then joins into the lacrimal sac.
So what is the ampulla?
So ampulla is basically a receptacle below the puncta, ma'am. So at the junction of the vertical and the horizontal canaliculi.
Yeah. So that is different from horizontal and vertical canaliculi. Okay. Yeah.
So it then opens into the lacrimal sac in the lacrimal fossa. Now this lacrimal fossa is formed by the anterior and the posterior lacrimal crest. Now this anterior lacrimal crest is formed by the maxillary frontal process of the maxilla, and the posterior crest is formed by the lacrimal bone. So now
Can you show them which are the two bones and which is the fossa?
So this is the lacrimal crest, anterior lacrimal crest, ma'am.
Which is formed by the somebody from the
Frontal.
Yes, one person at a time. Who was the mic first? Yeah. What's your? You can introduce
Ma'am,
yourself and then
Yes,
tell.
ma'am. I'm Dr. UPC, ma'am.
UPC.
The anterior lacrimal crest is made up of
Upper
the
palpebral consider. My full name Utsava. No, sorry.
Ujjwal Pratap Chakrabarti.
Ujjwal. Yeah, right. Yeah.
And the anterior lacrimal crest is made up of the frontal part of the maxilla bone.
Very good. And
Ma'am,
the
the
posterior
posterior
lacrimal
crest is made up of the lacrimal bone. I'm Dr. Shrishti.
Good. Okay. And what is that line in between? Can you see that in the fossa there's a small suture line, right? Everyone can see that? Just point that out. Yeah. Anybody can tell me the importance of that? Okay. I think Oviya will be explaining during the surgical procedure. Okay.
So now from the lacrimal sac, lacrimal sac then extends into the nasolacrimal duct, which is made up of two parts, the interosseous part and the meatal part. The interosseous part and then extends into the bony septum, which then opens into the inferior meatus guarded by the valve of Hasner.
Now go back over here, please. So the nasolacrimal duct has two parts. What is the bony septum that you were talking about? There's an intraosseous portion and there's a meatal portion. All right. So what are the parts of the lacrimal sac? Fundus, body, neck and all. No? It's only fundus and body. This is great. So this is the fundus of the sac, like how the uterus has a fundus, right? So this is the fundus of the sac and this is the body of the sac. So these two parts, then the NLD has two parts, which is the intraosseous portion and the meatal portion. Canaliculi has vertical and horizontal. Is that clear, the anatomy? Okay, so this is the common canaliculus. If there's a block here, it's a common canalicular block. If there's a block in the nasolacrimal duct, it is an NLD block. If there's a block in the canaliculi, then it's a canalicular block, whether proximal or distal depending upon the location. If the puncta is atresia or there is not formed at all, then it is that a block is at the level of the puncta. So basically the block can be anywhere in the pathway. Is that clear? So when you do syringing in JCOC, you should notice from where it is coming out. So what kind of block can it be? Okay. Can you please go back to the previous anatomy slide over here? Yeah. So now this is the medial wall of the orbit. Am I correct? Yeah. So this is the frontal process of the maxilla. This is the maxilla which is going towards the frontal bone. So it's a frontal process of the maxillary bone. Okay. Then the lacrimal bone. What is this bone? Eighth point. So if you open here, what will you see inside? Yes, so it's a sinus, right? So if you open this, you will see the, if you make a hole in this fossa, what will you see? You'll go into the nasal cavity, right? Okay. So you can actually damage the eighth point bone during a DCR. Sometimes even this bone you can, damage. So walls of the orbit, when we talk about the medial walls, we should come from anterior to posterior. Frontal process of maxilla, lacrimal bone, ethmoid bone, body of sphenoid. Is that clear? So, and what is this? These are the two crests. These are the prominence of each bone, and it's like a fossa. All right. Now, can anybody tell me what is the full form of Rho+, one of the first years? Yes. So, when the sac is situated here and when that is filled with fluid, when you press it, there is regurgitation of pus or mucus collection or whatever there is. Okay? Yeah.
Now we'll be talking about the medial canthal tendon. It's a very important surgical landmark. So basically this tendon is formed from the orbicularis oculi. That muscle has two parts. You have the preseptal and the pretarsal part. They form a medial extension to form the MCT. The superior and the inferior crura of the muscle forms the common MCT, which then divides into an anterior and the posterior limb. The anterior limb of the MCT, it comes in front of the lacrimal sac and attaches to the anterior lacrimal crest. The posterior limb goes behind the sac and forms the posterior joins at the posterior lacrimal crest. This anterior limb is very important because that's what keeps the puncta in position, ma'am.
Not really. So as she told, there are three limbs basically, anterior, posterior and superior. So the posterior limb of the MCT forms the shape of the lid, like how it goes inside. If that is, like if you say you have an injury, if the posterior limb is affected, then you can have a medial canthal dystopia, sort of like the distance will be altered. Okay. So but if the anterior limb is injured, if anything happens to the anterior limb, the shape is not altered. So most of the time during DCTs and DCR, we disinsert the medial canthal tendon anterior limb, and there is not much of significance to that. So that's why we disinsert it. Otherwise we won't be. We will just retract it and then do the DCR. There are some surgeons who just retract the medial canthal tendon and do the DCR without disinserting it. But most of us do disinsert the anterior limb of the medial canthal tendon, not the posterior limb. Is that clear? So it can cause something called so if the medial canthus, the posterior limb is affected, you will get a telecanthus. Okay. Is that clear? Yeah.
Now we come to the tear drainage physiology. So what happens is when we blink first, the upper and the lower puncta, they get opposed. So when the opposition happens, there is also a contraction of the orbicularis muscle. So that leads to squeezing of the sac and the canaliculi. So that drains out the tear from the canaliculi and sac into the NLD. And next, when the patient opens his eyes again, there is it gets unsqueezed and the tears, and there is a negative pressure formed in the sac and the canaliculi. So in that way, the tears present on the eye, it gets sucked in, and then the backflow from the canaliculi is prevented by the valve of Rosenmuller. So this happens in a cycle. So NLDO.
So when do you think the pump can be affected in any situation? Right. So the pump mechanism is primarily because of the orbicularis, the fascium of palsy, or with age also the pump mechanism can be affected. And one more thing I wanted to add, can you go back to the MCT slide? So this is the area of the medial canthal tendon. Can you all see that? Yeah. So the fundus of the sac is above the medial canthal tendon. Go back to the previous slide. I think the picture is clearer in that. Yeah. Here will be the medial canthal tendon. The fundus will be above. Right. So, but whatever collection because of a normal primary nasolacrimal duct obstruction, the swelling will be generally below the medial canthal tendon. So, that is an important clinical feature. If any mass or any swelling extends above the medial canthal tendon, then it is not a normal or regular NLD block. It can be even a malignancy. Because why? Anybody can explain? So, suppose there is a tumor and the NLD is blocked because of the tumor, then also Rho plus may be positive, right? So, but the growth will be, it will infiltrate through the MCT and above and extend above as well. But if it's just a regular fibrotic block here, it's just going to be fluid which gets collected in the sac. So, the medial canthal tendon is quite tight. So, all the fluid will be settling down only. So, it doesn't go above the medial canthal tendon. Is that clear? You all got it? Yeah, okay, so that's an important point. When you say there's a swelling in the medial canthal area, say like even in a primary nasolacrimal duct obstruction, you should see whether it extends above the medial canthal tendon or not. Okay.
There are two types of nasolacrimal duct obstruction, the congenital and the acquired. In acquired, you have primary acquired nasolacrimal duct obstruction and the secondary acquired. Now we'll talk a little about the congenital NLDO. So it occurs secondary to a failure of canalization of the nasolacrimal duct, and usually the obstruction which occurs at the level of the valve of Hasner. So now this obstruction, it could be a persistence of a membrane, or it could be a narrowing of the meatus, or it could be a bony obstruction as such. So 70% of newborns, they are born with an imperforate valve of Hasner, out of which 95% of the babies, they undergo spontaneous resolution by 1 month. The rest 5 to 95%, they only resolve spontaneously in 1 year. So now there are variations of obstruction in a congenital NLDO. The first being abruptly ending onto the vault of the meatus, or it's buried on the lateral wall. Otherwise, you have the NLD ending blindly into the inferior turbinate, or you have it blindly ending into the medial maxillary sinus wall, or it ends into a bony non-canalized nasolacrimal canal, or there is an absence of nasolacrimal duct as such.
Okay, just go back. So, this is an important thing. The most common type of block in a congenital nasolacrimal duct obstruction is, so what is the primary cause of CNLDO? What is valve of Hasner? So, right at the end of the nasolacrimal duct when it opens into the inferior meatus. So, that's it's a valvular block. So, that is the most common block, which is why when we do probing in children, we feel a pop because the valve of Hasner is opened up. So, that is the most common. Okay. So, but there are other blocks like in these cases, sometimes wherein the bony nasolacrimal duct, I told you, right, there are two parts to the NLDO. It may not even be formed. In that case, the probing will not be successful. Alright. So, generally we wait up to how many months for canalization on its own? 9 months.
Patients typically present with tearing, mucopurulent discharge, or both shortly after birth. The clinical features are chronic epiphora, eyelash matting, increased tear lake, accumulation of mucoid discharge, skin changes in the lateral border of the lower lid. This is due to chronic irritation and irrigation, and Rho plus is positive.
So, what is the picture showing? Anybody? Next, you can pass on the mic after each person. The next person is sitting. Yeah. You can introduce yourself and then.
Hello, Ma'am, I'm Salil.
Yeah.
Ma'am, it looks like a secondary infection due to
Very good.
nasolacrimal duct obstruction.
So, what is it called?
Acute dacrocystitis.
It's an acute dacrocystitis, right? Will you check Rho plus in this patient?
No, ma'am.
Yeah, because there's a lot of inflammation. The whole sac is inflamed. Only when there's a fluid collection, you press it, it's going to give a positive Rho plus. There's a fully inflamed and pus is there, you should not go and press the baby's eye. Okay, you should give oral antibiotics. Now, can this progress to anything? It can develop into an abscess, it can create a fistula. Anything else? Tell.
Ma'am, cellulitis.
Cellulitis,
Yes.
it can be preseptal, it can become postseptal, it can become orbital cellulitis, all that. So, prompt treatment is essential. If it is required, you have to drain the abscess, or generally oral antibiotics are sufficient. Once the acute inflammation resolves, then we treat the management, right?
Primary acquired NLDO. So in this, the obstruction is caused due to a recurrent non-specific inflammation of the NLD mucosa, which then leads to edema, subepithelial fibrosis, progressive luminal narrowing, and obstruction, with proposed contributors including anatomical narrowing, hormonal factors, microbial factors, and nasal abnormalities. In secondary acquired NLDO, you have inflammatory, neoplastic, traumatic, and mechanical causes. Inflammatory could be due to an endogenous cause like sarcoidosis or vaginos, or exogenous due to burns, allergies, eye drops, or radiation. In neoplastic, there could be primary tumors from the lacrimal drainage system like papillomas or lymphomas, or secondary arising from the orbit or the walls like basal cell carcinoma, squamous cell carcinoma, etc. In traumatic, it includes both accidental and iatrogenic insults. In mechanical obstruction, the obstruction could be anywhere along the NLD, like mucoceles or dacryolytes.
Okay. So, yes, the next person. So, how many secondary NLDOs have you seen? All the Rho plus positive patients were just primary NLDO. Any? None of, no traumatic you have seen? Not even in oculoplasty posting? Okay, so we do see a lot of secondary NLDO obstruction. Okay, so most common is primary nasolacrimal duct obstruction. But can you go back to the causes? If you see the causes, it can range from so many causes starting from malignancy onwards. So you should not miss that. So how will you pick it up? Yes, if it's a tumor, I just told you that is one point. Should also look for any proptosis or EOM limitation, and also all patients undergo a nasal endoscopy to rule out any tumor from the nasal cavities, right? So that is important. History of trauma, many times they may have a secondary nasolacrimal duct obstruction, but you may not have taken a proper history and not done a CT scan to actually diagnose it. Okay, inflammatory causes, I think you guys may have seen, but it is maybe underdiagnosed. But that is also a part of it. Okay, so you should not miss a secondary cause of NLDO, especially neoplasms, because it changes the whole life of the patient if a malignancy is missed. Okay, so you not harm the patient. So missing a diagnosis can harm the patient. Only when the patient has severe proptosis, grossly when sitting in the OPD, you know, you pick up a diagnosis that is anybody can make. You pick it up early, then is your clinical skill matters, what you have learnt from here.
We come to the evaluation part of NLDO. The most important is history taking. So what all should we ask? We should ask the duration of the symptoms, the type, constant or intermittent tearing, the laterality, any medications was used, any skin disease, allergies or any prior ocular infections like conjunctivitis or herpes, or prior radiation therapy, sinus disease or sinus surgery, trauma or any other systemic disease. Now, examination. On inspection, we should see the facial and periorbital symmetry. The eyelid should be inspected for any entropion or ectropion. Eyelash should be checked for the tracheasis or dystachiasis. Any inflammation or discharge or fistula. Number, we have to see the puncta to check if the correct number size position is there, and how the peripunctal area is. The conjunctiva, cornea and tear film height should be seen. In this image, you can see now there are two punctas. So this is an abnormal finding, out of which the medial puncta is the
What is it called
anatomical
when
one.
you have multiple puncta? Okay, supernumerary puncta, right? Okay.
On palpation. We have to see whether the swelling is near. We have to check for the swelling near the medial canthus. If it's above or below, the rhopla should be checked, and eyelid laxity should be seen.
Above or below what?
The medial canthus.
Okay. So now, Mansi, can you tell me what are the causes of watering generally? How would you classify that? When you evaluate watering, the causes can either be dash and dash.
Ma'am, first it can be because of age factor.
Generally, any cause of watering.
Ma'am, it can be divided into two, like hypersecretion
Right.
or maybe it is obstruction. Drainage is
That
not
is
happening.
called as?
It is called as epiphora.
Epiphora.
Yes,
Epiphora is only when there is a problem in the drainage system, wherein the oculoplasty person comes in. Okay. Any hyperlacrimation, which could be anything, like example,
Ma'am, dry eyes in response to it, reflex secretion in dry eyes, it can happen.
okay, any other cause for hyperlacrimation? Yes, conjunctivitis, foreign body, anything on the
body.
ocular surface, allergy, all that, right? So that's why it's important to examine the eye and take a history. Okay. The drainage issue patients will have a chronic history, right? And history of discharge is a very important history. Why? Who is sleeping in the second row? What's your name? Tell me, what is the importance of taking a history of discharge? Okay, so I'm specifically, okay, next person, you can go back to your seniors, right? So, so when we're talking about a block in the nasolacrimal duct or anything in the drainage system, is the history of discharge important?
Yes, ma'am. Type
Okay,
of
tell me.
discharge is important.
Okay,
Like mucoid or purulent discharge will change. Like it will go.
can a patient have no discharge? If
It,
there's a nasolacrimal duct block
yeah,
without
it
any
can be
discharge?
simple regurgitation. No.
So what I'm trying to say is
Fibrosed
go back
stenosis.
to the anatomy slide. No, just sorry, let us go back. Yeah. So see, if a discharge comes only when there is some sort of infection or inflammation or some collection of pus anywhere, right? So if there is a block just in the puncta level, if there's a punctal agenesis or there is a canalicular block, a fibrous block, you're not going to have any collection of discharge in that case. But if you have an NLD block here right down, there's going to be accumulation of fluid, stasis of tears, then inflammation and infection. So then only you get discharge. So only after the level of a common canalicular block will the patient even complain of any discharge. Otherwise, they'll just complain of simple watering, no discharge, no matting, nothing. So with the history itself, you can make out. So even when a child comes to you with history of watering, you should ask whether it is just watering or whether there is discharge and matting. If there is discharge and matting, that means technically the block can be in the distal portion. But if this child is complaining of only watering, no discharge at all, it could even be a punctal agenesis. So your examination is so important and your history is also important. Duration is important and all the rest of it also. This is an important cue so that in children especially examining is a challenge, right? So every bit of detail that you can get, you should get.
So now what are the tests we do? So
Yeah,
the first
one
being
more thing, sorry. Oviya, can you just go back? So these set of things that she has written, entropion, ectropion, all of this cause a hyperlacrimation. But it's a lid abnormality. So not all watering is because of NLD block. So you should look at the lids and then look at the puncta, everything. Okay, examination is important. This is what the take home message would be for you all right?
Now we come to the specific test. Now Rho+, that is a regurgitation of fluid on pressure over the lacrimal sac. In this, we apply pressure over the lacrimal sac fossa. So we get different findings. So the first, if we get a clear mucoid or a mucopurulent regurgitation, we could interpret it as a nasolacrimal duct obstruction. But if we get a regurgitation of a blood-tinged fluid, it could be due to any tumor or any dacrylith. If there is no regurgitation of the fluid and the sac still remains dilated, it means it could be an encysted mucocele. Or if there is no regurgitation, but the sac empties into the nose, could be because of an atonic sac.
So what is encysted mucocele and why is there no regurgitation? Somebody was answering? Continue. Okay, so atonic sac, encysted mucocele, you want to check that, right? So now if the block is only here, then only when you put pressure here, the fluid is going to come out through the upper puncta. Now in encysted mucocele, what happens is, this is here, there's a valve called as Rosenmuller, right? Everybody knows that. And this valve of Aston or the NLD block. So when both sides are blocked, what will happen? There's no way that nothing is going to regurgitate out because it's blocked here as well. So there will be like a huge, quite a bit of a swelling, like a mass itself you will palpate there. And it is cystic. It's just collection of the entire fluid over there. So that is an encysted mucocele. Do you understand? So now suppose you do syringing in an encysted mucocele, what finding will you get?
Regurgitation.
Yeah, so it will just go like this and come out. But when you do a probing, you will get a soft stop there. Understood? It won't happen in the same time. Okay, and sometimes even when there's some secretions from the sac lining also can happen. It won't happen exactly in the same time. That's a very good question though.
The next is the dye disappearance test, which is very helpful in examining children. So the fluorescein is placed in the inferior fornix of both the eyes and is observed under the cobalt blue light. The amount of dye remaining after 5 minutes is noted. So in a normal lacrimal system, the tear film clears after 5 minutes. In case of any obstruction, it stays longer. A Jones dye test. It assesses the flow of tears through the lacrimal sac and the NLD.
Skip this, is more academic.
So probing is performed when a canalicular block is suspected during syringing. and it is also done to determine the site of the block in the canalicus.
No,
Now-
probing is not done only to get canalicular block. No, you talking about hard stop,
Yes,
stop, so NLD block. It is to differentiate what type of block it is, not only for canalicular block. NLD block, canalicular or CCB, whatever it is. Okay.
So if there is an obstruction noted within 6 millimeters of the punctum, it is a proximal canalicular obstruction. Obstruction beyond 6 millimeter is a distal canalicular block. Now hard stop and soft stop.
So
On
can you
probing,
go back? Are you explaining the syringing findings more than that?
there's another slide now.
So in a canalicular block, what will be your syringing finding? Very good. So it depends on where the block is. It will be from the regurgitating from the same punctum, right? So if it's a common canalicular block, the opposite punctum, correct. Go back. So when it is coming from the same punctum, then you put the probe in and you measure how much the probe has passed. So depending on that, it will be a distal or a proximal canalicular block. Okay.
Hard stop and soft stop. So on probing, if we reach up to the lacrimal sac and we hit the bony wall, it means the common canalicular pathway is patent. And if Roplas was positive in that patient, it could be because the NLD was obstructed. But in soft
in a
stop,
Roplas positive, that means it's NLD obstruction only, not could be. It is always an NLD obstruction if Roplas is positive. Whether it is primary or secondary, you have to diagnose. But if Roplas is positive, that means the NLD is obstructed by something. Most likely primary, but you should rule out the secondary causes, right? So this everybody got, right? This is important. So hard stop is because you are feeling the bone directly. Yes, continue.
so in soft stop, because the block is in the canalicular pathway due to any fibrosis or growth, there is a block in the canalicular pathway. So we feel a soft stop. We don't
So
reach
there is
the
no
bone
growth,
directly.
there is fibrosis, it's a soft tissue block, right? So this is the common canalicular. So from starting from any like proximal or distal, only canalicular block or common canalicular block, which is a CZB, right? So in that there's it's soft tissue, fibrotic tissue, right? So when you pass the probe, you'll feel a soft stop. Whereas when there's an NLD block, you will get a hard stop. Is that clear, everybody? So when you do syringing, if the fluid regurgitates from the opposite puncta, it can be either dash or dash. Can somebody else answer that? Yes, so it can either be CCB or an NLDO block when the regurgitation is from the opposite puncta. Then you do probing to differentiate whether it is CCB or hard stop. Is everybody clear on this? Now, why do we need to do so much? For a CCB, what is the treatment, and for NLDO, what is the treatment? Okay, we'll discuss that. But what is important is an NLD block needs to be treated before any intraocular procedure. That is why you are all doing syringing for every patient in JCOC. If it is an NLD block, we have to do a DCR. We should not do intraocular procedure. Why? Yeah, so there is stasis of fluid and it can lead to infection. So it's a site of infection actually. So you should not do any intraocular procedure. But whereas if it is a common canalicular block, is there any stasis of fluid or any reason for any infection? No, it's just going to be come out immediate regurgitation from the opposite puncta and there is no stasis of fluid. So they can undergo a cataract surgery. This is why most of the patients come from JCOC. So we will differentiate it from CCB to NLDO block and then plan the management as such. For what? For which case? CCB it's not required. We don't do swab actually, but it's up to the surgeon. Sometimes they do, but we don't advise a swab prior to the intraocular procedure. No, you generally see this is a debatable topic. Yeah, so there are two ways to look at it. So if there is stasis of fluid, then only there is infection. Now they may be Roplas negative but a hard stop. Syringing may not be patent. So maybe the sac is atrophic. It's not as big to collect the fluid. So if you know that there is NLD block, you cannot really go ahead with the intraocular procedure. But if you don't know but Roplas is negative, in an atrophic the chance of infection is less. So most of us, if you see, Roplas is the most important finding. So if Roplas is negative, then you are safe. But if you do a syringing and if it's not patent, if it's hard stop and if it is an NLD or documented it, if there is a block, then you'll have to do a DCR. But it's important how you check the Roplas. So rho plus, if you don't check properly, it will be negative only. Okay. So that is why they are doing syringing in JCOC, because it should be done very. How will you do it? Can one of you describe how you will do it? In children and adults, any difference is there how you do it? Who is the next person on?
Put pressure over the sac and see
Yeah,
if there's
but where is it?
regurgitation.
How you know
Yeah,
where it is? Where you have to press? You have to
below
follow
the
the inferior
medial
orbital
canthus.
rim. Okay, and then you will find a fossa. You have to press. Okay. So now in adults, okay, all of us have. So try to palpate. You will see a palpate the fossa. Did you all palpate that? Felt it? Only if you press there, rho plus will be positive. If you just press below the inferior rim, it will be negative only. So in children, the fossa is very small. So you can't use your finger and press. You should use a bud. Okay. Because if you put your big finger and press over the sac, it's not gonna be positive. But if you use a bud properly and then press it, then it will be positive. Okay. So you have to examine even small things. Unless you do it properly, you will miss it. Okay.
To syringing. In syringing, after applying topical anesthesia, the puncta is dilated and saline is injected using a lacrimal cannula. So now this is a flowchart about the findings.
I think this we have just discussed. Everything is clear on this, right? Though if when you do syringing, patient should not have pain. Okay. Then you should stop doing the pushing the fluid and then leave it. It will canalize. You can't really do anything about it, but usually it will be patent only. So when you do the syringing also, there is a technique to do the syringing, right? So how you press it down, because 2 millimeters it goes down. There is a vertical canalicus. Then it becomes horizontal. Press it a little bit and then you turn it inside. You stretch the lid laterally. So then you will not cause a false passage. So in adults, if you do syringing easily in uncooperative patients, all that, it's sometimes it can be a challenge. And if the puncta is so small you can't see, you have to dilate the puncta and then try it and do it under the slit lamp. Right? So if you are well versed in doing adult patients, then in pediatric patients you can do. Because you get only one chance for children, right? Once you can't cause a permanent tearing for a child. Okay, so it's very important. So practice doing all of these things, punctum dilatation, and examine the patient. If the patient complains of watering, I know in JCS you all do only rho plus, and I don't know whether rho plus is done. No, rho plus is done and then syringing you do. But you should also look at the puncta, lid laxity, how the position of the lashes are, if there is there trichiasis, all of this also you should see. And take it as a challenge and do punctum dilatation. They're not going to ask you to do it, but you can do punctal dilatation, you can do probing. It's quite simple. Right? To diagnose what is the cause of watering.
Imaging investigations done usually are dacryocystogram, dacryocintigraphy, nasal endoscopy, and dacryoendoscope.
So in this, can you please go back? Nasal endoscopy is done for all patients. Okay. CT, DCG and scintigraphy is done mainly in traumatic cases. Okay. So indications of that. And sometimes if it's a failed DCR or even in children if there's anomalous pathway, then we can do it.
The dacryocystography defines the lacrimal sac anatomy. So there a radiopic dye is pushed into the canalicula's system and immediately imaged. So every 10 minutes the films are taken and if they are checked to see if there is any delay in drainage. So this is helpful in determining the level of blockage, the extent of the sac maldevelopment or any tumor, but it does not help in determining the lacrimal drainage physiology. In contrast, dacryocystography is done in cases indicated in cases of suspected lacrimal sac mass, dacryolith, or traumatic nasolacrimal duct obstruction.
What is contrast dacrocystography?
Contrast dye like lipidol.
You mean to say general contrast, MRI with contrast?
Yes, ma'am.
Ma'am, we can put, we use dye basically to see the pathway. This is like we use the dye iodine we did, whatever the dye we can use, ma'am. Yes, ma'am.
That is a dacrocystogram. This is not a. This contrast dacrocystogram is very confusing terminology. That is incorrect.
Okay.
Okay, it's a dacrocystogram. Can you go back? Yeah, so dacrocystography, it's a CT DCG. If you say CT with contrast is different. That is, we give IV may contrast. Do you understand? You give contrast IV and then you see how the soft tissue is behaving. Okay, this is a CT DCG. This we put the dye only uh, in the eye. Okay, in the conjunctival sac. There are two ways to do it: by drop method, wherein you just put the drop in the conjunctival sac, and the other is they do syringing itself. But here we do drop method only. Okay.
So Dacry scintigraphy. In this, we insert gamma ray emitting radionucleotides into the conjunctival sac, and the imaging is done with a gammagram. So this is to evaluate the physiological flow of the tears. So this is to evaluate the physiological or the functional flow of the tears. The procedure is easy and non-invasive, but it does not provide any fine anatomic detail, and it helps to differentiate functional obstruction from the anatomical obstruction. Endoscopy is what is generally done over here.
We do everything over here. This we do for all patients. Okay. Okay. What do you see here? This is the middle turbinate, first pass. So this is the inferior turbinate. This is the inferior meatus. Okay. Now we are elevating the inferior turbinate here, and over here. Okay. So this here only you will get the opening of the duct. Is that clear?
Dacryoendoscope. So it's the microendoscopy of the lacrimal system for the direct visualization of canaliculi sac.
This
and
is
the
a
NLD.
recent advance. We don't have this machine here, but this would be good. Okay.
So the other investigations that are done are digital subtraction or dacryocystography, echography, CT or MRI. So now we come to the management part. So first, management of NLDO. So if when a baby is diagnosed with CNLDO, the conservative management is what is preferred first. So we do Krigler's massage and topical antibiotic till 9 months of age.
So we don't give topical antibiotics for all cases, though some people advocate it elsewhere. Only when there is active infection we can give, or generally we only explain massage to the patient. Okay.
So if within 9 months the condition resolves, we only observe the kid after that. If there is no resolution beyond 9 months, we do syringing and probing. Even after syringing and probing, there is no resolution, we repeat the procedure. And in spite of repeated procedure, if it doesn't resolve, we do nasal examination to rule out any turbinate hypertrophy, narrow meatus or polyp or any other cause of obstruction.
So only if it's failed, we will examine the nose. We examine the nose in the first sitting itself. You have an image of the probing also, right? Video. Okay, so the video of the massage, lacrimal massage, yeah. So you all can see this, right? This is how a typical massage needs to be done, with the little finger, with the nails cut properly. Okay. Good pressure over the lacrimal sac, and then you bring it down like this. Okay. So how many times should it be done? Each time you should do at least 10 strokes like this. You can do it about 3 times a day. Okay. So we do this till recommended till 9 months, because till 9 months they can resolve. If it doesn't, then we do probing. Correct? Yeah. You can show the probing.
Invasive procedure like probing and irrigation is done under GA within the age of 1 to 5 years. Silicone tubing for intubation under GA can be used as either a primary treatment on initial probing or after failed attempts of probing.
So generally we don't put a tube stent for every single patient. If it is an easy probing, only probing is done. If it is a difficult probing, then we put a tube. If the first time the probing has failed, after probing also the mother has to do massage regularly. If they don't do it, again it can stenose back. So in spite of that, if it is failed, then we can attempt the second time we do probing, we can do an intubation. Inferior turbinate fracture can be done even in the first sitting when we take a probing, because we will be examining the nose and we do probing under endoscopic guidance only. Okay, unless you see the probe in the nasal meatus, the inferior meatus, it's like you have not done a proper probing. In the past, they used to just do metal on metal touch without an endoscope. So, but then we can't say
it can be an anomalous type of a block. You may think that, yeah, you have done probing, but it is actually not a successful probing. Did you all get it? Understood what I said, right? Yeah.
Persistent NLDOs, CNLDOs, in spite of, we do repeat probing or balloon dilatation or fracture of the inferior turbinate to displace any bony obstruction in the NLD. So success rates are more in mono or bicanalical probing, more than dilatation, more than repeat probing.
So the probing, we generally do it through the upper puncta. Okay, and when we put a tube, we prefer to put a monocanalicular tube, wherein the tube is put through one puncta only and not through both the puncta. Though either ways is okay, because if you put it through the only one puncta in OPD itself, you can remove the tube. Now this is a probing, you can all see that, yeah. So you can feel the heart stop, you can see, no, that
View of the probing.
So can you tell them how you do the probing, any technique? So you can see now the probe has come into the correct passage. So in this also you can create a false passage. So now in the probing that you do in OPD is only hard stop and soft stop. Here, once you reach the hard stop, then you bring it down through the nasolacrimal duct. Okay.
Management of acquired NLDO, the mainstay of treatment is
I
dacrocystorhinostomy.
have another question for our fellow. So suppose it doesn't come into the inferior meatus. What will you do?
During the procedure, we try to visualize through nasal endoscopy. The probe may come through the middle meatus, or like in rare cases the superior meatus, or it may not be visualized in the nasal cavity. So ma'am, we will retract the probe and then like redirect the position of the probe and try to do it. Multiple times we should not attempt, and repeated if it is getting like we're not being able, then there may be some internal false passage, then we may have to take a call whether we need to do an external DCR for the patient.
There should be a giveaway sensation at the end as we go downwards and posterior.
Yes. Tell the way direction in which the probing has to be done.
So it should be down firstly from punctum canaliculi and then downwards, backwards and posteriorly.
Yes. So that direction is important. Okay. So if you go in the wrong direction, you will create a false passage. Then obviously a probing is not successful. It's because your expertise are not adequate. Okay. So you should be very careful and you should do the probing because it's sort of like a blind procedure only. You go by the feel of it. Okay. So you can try repeat probing if it's not come into the meatus, and assume that we're all very skilled professionals. If it is a block like one of the types which she showed in the picture, like there may not be a block, a canal itself. In that case, you will feel a hard stop when you do the probing. It will not come out into the meatus, but it will be very hard. That means the whole thing is blocked. Or it can be a buried probe wherein it goes all the way down to the floor of the nose. So in those situations, you have to do an external DCR. Though generally we recommend DCRs after the age of 3 years. While doing the first time itself, if the type of block is a bony block or where it is not formed at all, you have to do a DCR only. It's not going to open up magically at 3 years. Okay.
So the mainstay of treatment in acquired NLDO is dacrocystorhinostomy, where it's a surgery done where a fistula is created between the sac and the nasal cavity in order to bypass an obstruction in the nasolacrimal duct. So the types of DCR surgeries are external, endonasal, ultrasound, laser DCR, conjunctival DCR.
So you can basically classify it as external and endonasal DCR, right? So in endonasal DCR, you can use an endoscope or you cannot use an endoscope. There is non-endoscopic endonasal DCR also. Okay, so in endonasal DCR, it can be endoscopic endonasal DCR and non-endoscopic endonasal DCR, right? And then there are lasers which we can use. I know everybody's like, can we really do an endonasal DCR without an endoscope? It can be done. Yes, there are surgeons who have done it, and some even do it now. But of course, we do endoscopic guidance only, which is easier. Um, so then we can use a laser as well, and then you have the CDCRs, wherein in cases where there's a canalicular block, we can do that as well, like a Jones tube and all that. Okay, so this is more for your exam purpose types of DCR asked in the question for you. Okay.
Advantages of external and endonasal DCR. In external, you have a higher success rate, the smaller learning curve, and doesn't require any expensive instruments. Endonasal, there is no visible scar and there's lesser bleeding compared to external surgery. There is a quick recovery, and any other nasal pathology can be addressed simultaneously.
So nowadays the success rate is comparable both in external and endonasal, but of course the gold standard has always been an external DCR. Very high success rate mean how much? 98%, really 98-99%. But there are a few who may undergo a failure. Alright, so the learning curve, of course, because endoscopic, you need a little bit more expertise, but at the same time, even external DCR needs quite a bit of expertise. And if you do a good external DCR, you can be a good orbit surgeon. It's because the anatomy is so small, you need to be very meticulous in the surgery. You can cause a lot of problems if you don't do a proper dacrocystorhinostomy. There are a lot of complications also that can happen in DCR. Okay.
Disadvantages. In external DCR, there's visible scarring, there's more bleeding, and there's increased chances of medial canthus injury, and more surgical time is required to do the procedure. In endonasal, there's lesser success rate and there's a steeper learning curve and requires more expensive instruments.
Can you please go back? So the other thing is the main advantage and disadvantage would be the scar, and that is scarless. And in endonasal DCR, we generally do it under general anesthesia. Whereas external DCR, we do it under local anesthesia. These are the two main pros and cons, both of them. Bleeding depends upon the case. It is not that in external you have more bleeding. Even in endonasal, you can have more bleeding. Okay. And chances of medial canthal injury and all very rarely happens. Of course, in very inexperienced hands maybe, but generally not. And surgical time again depends on the surgeon. The external DCR, some surgeons will be faster, endo DCR they may be slow. It depends on what you're trained in. Okay.
So indications of DCR: persistent CNLDO in spite of even after failed therapies, CNLDO associated with mucocele dacryocystitis and not responsive to other treatments. Pando with chronic dacryocystitis, mucocele of the lacrimal sac, and to relieve the infection of the sac before any intraocular surgery, Sando.
1 second. So indications of DCR is any form of nasolacrimal duct. Secondary pathologies, if it's neoplasm or a cancer, you don't do a DCR. You will do a DCT if it is a malignancy. Okay. And in children, apart from just regular CNLDO, you can have something called as dacryocystocele. Yeah. Wherein it's something similar to an encysted mucocele. I told you, right? Like Rosenmuller and NLD both level blockage. But here amniotic fluid is getting collected in the sac. So that acts like a culture medium. So in these children will have recurrent acute dacryocystitis. So that's an indication of early probing in children. Is that clear? This is a common question you may be asked. It's important to know. And what are the other indications of early probing in children? Usually we do probing at what age? After 9 months. So when will you do earlier than that? That is called as early probing. So one is dacryocystosis because they have a tendency to have recurrent acute DACs. Then other common indication? What surgery? Intraocular surgery. Any sort of intraocular surgery, just like how we don't do cataract surgery in plus positive cases, even in children is the same. So then we have to do it. So we have done DCR even in very young children, like say 3 months or 6 months. We have done because the child requires a intraocular procedure. Otherwise, there's no indication to go in, dive in and do anything before 9 months. Is that clear? Okay, and when you talk about secondary causes of nasolacrimal duct obstruction, it's a if it is a traumatic case, yes, you can do a DCR. Definitely, you should do. Sometimes you may even need ENT backup for that if it's complicated. Okay.
Contraindications of doing the surgery. The absolute contraindications are atrophic rhinitis, malignancy, or any fungal infection like rhinosporidiosis, dry eye, or acute dacryocystitis.
So, in this absolute contraindication, the only absolute contraindication is malignancy. Okay, wherein you have to do a DCT. Rhinosporidiasis, we do a modified DCR nowadays. Okay, where we keep a very small frill of lacrimal sac tissue. Okay, in acute DAC, you will not do a DCR, but after the resolution, you will do a DCR. That is not a contraindication. After it resolves, then we do a DCR. Of course, in the acute setting, you don't do a DCR, but you can't write it as an absolute contraindication. Okay, dry eyes, why do we prefer to do a DCT than DCR? Because you want retention of tears. We are doing punctal cautery for these patients, right? So, not in all dry eyes. If very mild dry eyes, you don't go and do a DCT. If it is severe dry eyes, check the shimmers and all that, then we do prefer to do a DCT. So, and again, is it a absolute contraindication then? It is a relative contraindication. You don't mention these causes. It is only malignancy, okay? Even atrophic rhinitis, yes, your DCR chances of failure is high. So, yes, you can consider a DCT. What is the other indication for, basically you're talking about DCR versus DCT, right? So, what is DCT?
Cystectomy.
Okay, what is done in that? And we don't make an alternate passage, correct? So, in elderly age group, we do a DCT rather than a DCR. Why? Yeah, somebody can answer in the mic.
Bleeding, lesser operating time.
Yeah, so generally this is a bypass route, right? We'll be making an ostium and everything. So in that case, not all elderly people will be fit enough for such a procedure. So we prefer to do a DCT. So only thing you have to explain in a DCT is post DCT patient will have persistent watering. But as we age, some amount of dryness also develops. So they may not even complain of much of watering. Is that clear? Okay. Oviya, tell me the ostium limits. This is another thing. In DCR, you make an ostium, right? You'll be discussing that, right? Yeah. Your video is there.
So before we do the procedure, we have to do a certain set of pre-op investigations. The first being pre-op NE.
What is knee? Nasal endoscopic examination. Yeah. This is the root of the middle turbinate. Okay. Laterally. Medially is the septum. So what are you seeing here in the inferior meatus? Anybody? Yes.
Structure in the inferior meatus. Ma'am, like a strawberry red appearance, it might be rhinosporidiosis, ma'am.
Yeah, they have typical spots on it. So you can see that grayish white spots on it. Rhinosporidiosis is a infestation. Okay. So not all patients are normal fibrotic primary acquired nasolacrimal duct obstruction. This is a secondary obstruction because of the infestation by what organism?
Rhinosporidiosis severi.
So that was just to highlight the importance of endoscopy.
So nasal packing. So we use a gauze soaked in xylometazoline or otrivin, name, and lignocaine with adrenaline. We then place the gauze. We pack the gauze in the middle meatus, and we direct it superiorly and backwards, and not push it posteriorly, ma'am.
Why?
Because it could go into the hypopharynx.
So much at all you want to push, no? Okay. So basically your pack has to be in the middle meatus area. Where is the DCR opening and where is the DCR open into which part of the nose?
Sorry, louder. Into the middle meatus. Where is the NLD open?
Inferior meatus.
Yeah. So sometimes you'll just pack the inferior meatal portion, which is not useful. Why are we packing?
Anesthetize.
We are
Prevent
going
bleeding.
to use the nasal mucosa in the middle meatal portion, right? In that area, right? So if you pack in the inferior meatus, there's no use. This all this lignocaine with adrenaline, all this is to ensure less bleeding. So your packing is important. So if you don't pack properly, there's no use of that pack. So when you do a DCR, how do we know that the assistant has done a good packing? You will see this gauze once you open up the sac, the mucosa. Once you open up the mucosa, you should see the sac. Then only the packing is good. Otherwise, the packing was not good.
So anesthesia, general or local? In general, we give for children or any traumatic NLDO or in young, uncooperative, extremely nervous or anxious patients, and is given during in endonasal DCR surgeries. Local anesthesia, it's a subcutaneous injection near the sac area, and there is infiltrate. We infiltrate up to the periosteum. So the common blocks we give here are infratrochlear, infraorbital, and anterior ethmoidal block, usually given in external DCR surgeries. Now this is a video of the external DCR procedure.
You can explain. Are you explaining?
So the incision is made medial to the medial canthus. It's a 10 mm incision, and the skin is cut with a 15 blade up to the periosteum, and the periosteum is then incised.
Now, can you go back? Can you restart? Okay. So first is incision along the antilacrimal crest generally. So that is the angular vein that you can see. So ideally you should avoid injuring the angular vein. This is the periosteal incision. Can you just pause it? What is periosteum? Yeah. Okay, so before we make the incision on the periosteum, we actually identify the medial canthal tendon. That gives it's a landmark, it's a surgical landmark. So then you cut the medial canthal tendon, you can disinsert it. Once you disinsert it, what will you see below is the antilacrimal crest. That area you make the incision, yeah. So now there are
Periosteum is elevated. In this, they're doing the NCT release after him. The antilacrimal crest is exposed, and the lacrimal fossa is exposed. So using a Ronger's punch, using a periosteum elevator, we first make the ostium, and then using the punch, we enlarge the ostium.
So the first where you use periosteal elevator to make a small opening, which would be at the junction, that suture line that I asked you initially, that is a weak spot. So you make a small opening and then you go ahead with using the punch. So this punch is called as the, what's the name of this punch? Kerrison's bone punch. Okay, there's another punch in glaucoma, so don't get confused. Okay, so then we make the ostium. What is the ostium? It's a bony ostium, right? Opening in that fossa, lacrimal fossa. What are the limits of the ostium? You can pause the video and tell the limits of the ostium.
Superiorly, it's the level of the medial canthal tendon. Inferiorly, up to the where the NLD opens, starting of the NLD.
Superiorly it is medial canthus, inferiorly it is at the starting of the NLD, and then we have anterior, which is anterior lacrimal crest, the posterior will be posterior lacrimal.
Superiorly is the medial canthal yes, ma'am. Okay, so the boundaries of the ostium is also important. You should know the boundaries, yeah. Yeah, above, right. Yeah, see, and usually we disinsert the medial canthal tendon, no? So automatically the full thing will get away. If you don't disinsert it, then only that tissue will be above. Like I said, there are surgeons who just retract it and then do the DCR as well. But we usually disinsert the medial. I usually disinsert the medial canthal tendon. Oh, like that you're saying.
little above up to the medial canthal tendon only you should do, because why, sometimes they'll have a low lying cribriform plate, so then you can have issues. Yes, you have a doubt? Yes, yes. See, you are not going so posterior, no. It will be just at the posterior lacrimal crest. So you don't have to make a very large ostium. Okay. The boundaries are being shown. Then after you make the ostium, this is the infiltration into the nasal mucosa. Then we make the fashion the flaps, anterior and posterior flaps. Posterior flaps we generally remove, we only keep the anterior flaps. There are surgeons who make suture the anterior flaps and also the posterior flaps. Yeah, still I think there are people who follow that, but we generally only suture the anterior flaps. Posterior flaps we remove.
The nasal mucosa flap is also raised.
Okay, so here we are anastomosing the mucosa, nasal mucosa flap with the sac flap. Okay, then we take a bite through the periosteum to keep it lifted up so that it doesn't sag down and cause a obstruction. So the flaps also, it should be of adequate length. It should not be very big, very long, because it can sag down. Okay, so quickly steps of DCR.
So after giving the after packing.
So incision itself, there are so many types of incisions, where the location and all that also. You guys can look up on that. Then first is the incision, skin incision, then is the dissection, subcutaneous dissection, then identification of the medial canthal tendon. Then you make a incision over the periosteum. Then next, what step will come? Yeah. We have reached up to periosteum. Then we elevate the periosteum when we dissect and get the lacrimal sac, we dissect off from the fossa. So at this point in time, if you don't do a good dissection, you can injure the lacrimal sac. You can amputate the flap itself, then you can't do a proper DCR. Okay, so your dissection at this point is extremely important. After that, after you dissect the lacrimal sac away from the fossa, then next step, exactly, then we punch it, right? Then we make the ostium. After you make the ostium, next you make the nasal flap. So when you are punching, you can injure the nasal mucosa. Sometimes along with the punching, you can punch off the mucosa also. So if you do that, then again you don't have tissue to anastomose. Okay, so you should do careful punching, and there are other techniques to avoid you should know when you punch, if you get the nasal mucosa bit along, then you know you're on the wrong plate. So if you know pick up early, you can still do a good DCR by salvaging rest of the mucosa. But if you punch off fully, then you have to do DCT. Okay. So after that, you anastomose the mucosa, right? Then we do the skin suturing. So grossly, the steps of external DCR, you will be asked. You will be asked about the punch, the boundaries of the ostium. So these are the common things that you will be asked. Punch name, what's the difference, all that you will be asked. Okay, this is from exam point of view. External DCR you should know. Endonasal DCR you generally will not be asked, but just for like a trivia question, in endonasal DCR, do we do suturing of the flaps? We don't suture the flaps and all in endonasal DCR. We just keep it in a particular position so that it gets mucosal lining just heals well. Alright. So, we are not going into endonasal DCR surgical procedure, but if you are interested, you can see it. We have a lot of videos of that as well. You are having it here. I think we'll skip it. I think this is the endonasal DCR. Anybody is interested in seeing, or we'll end the class? Okay.
First, the mucosal flap is raised with a crescent knife and it's cauterized. Then we use.
So this is just marking where you're making the incision, and over here we make an incision in the nasal mucosa. So everything is reverse. Okay. So then here we are punching again over here. Then we will see the lacrimal sac over here. There's a probe which is put through the sac, you can see it. So adequate ostium should be made endonasally also. Okay, I think, yeah. Okay.
So the intraoperative complications of DCR, hemorrhage or any injury to the common canaliculus while opening the sac or improper probing or punching, CSF leak due to the penetration of the cribriform plate, shredding of the lateral nasal mucosa during punch or improper bone removal, failure to completely open the inferior portion of the lacrimal sac leading to lacrimal sump syndrome. So there's failure.
Sorry, can you just repeat what is lacrimal sump syndrome?
Because when we superior part of the when the inferior part of the ostium is not properly made, then there is a collection in the inferior part of the sac, so that will also again lead to regurgitation. So patient will have.
Yeah. So basically in lacrimal sump syndrome, the syringing will be patent, but the opening is very high up. So the tears don't actually go. Though the ostium is good, but the location is not correct. The ostium is open, but it's not adequately placed in the correct position. Okay, CSF leak is a very important complication, which is more commonly seen in endonasal DCRs. External DCR hardly ever we have that, but it can happen because in endonasal DCR we use a drill sometimes, so that can cause. Okay, so that's why above MCT we should not do it. Okay, then
Post-op complications are hemorrhage, infection, incomplete improvement and persistent tearing, early loss of the silicone tube if intubation was done, fibrosis or leading to occlusion of the ostium, synechia between the middle turbinate nasal septum or the lateral wall, and need for an additional surgery due to failure of the DCR.
so what is the most common cause of failed DCR? Though I said that 98% success rate. What are the causes of failed DCR? Whether experience or inexperience. Yeah, fibrosis of what? Okay, then it closes up, right? Okay, so then you have not done this thing. Any other cause? May not be the surgeon's fault also at times.
Infection.
Huh? Yeah, sometimes the canaliculus will get fibrosed. The patient may have some other cause, like SJS or some other diseases, also surface inflammation can be there. You can have a canalicular block. You might have done a good ostium, but the canaliculus is blocked. Okay. So if you have not done a good ostium, yes, it is the surgeon's fault. Okay. But in children and in young patients, it can close faster. That's why we use mitomycin, we can use, okay, and we can put a tube in intubation in complicated cases like traumatic DCRs and all. Chance of fibrosing closing, ostium closing is more. So those cases you have to do some intervention to prevent that. So CCB canalicular block is the most common cause actually. So if the patient has a common canalicular block post DCR, you really don't have to go and do a revision DCR. If the patient is comfortable, no problem, he's not complaining much about watering, we can leave it. But of course, if they do have persistent watering, they are symptomatic, then you have to put DCR and put a tube. Okay, I hope you guys have learned something useful out of this class. Thank you guys.